thank you very much for you and your group to having really agreed to take our invitation. Thank you very much. I invite Professor Dr. Mahendra Bhandari. He need to leave somewhere. I request him to give a message and little bit tell about the Vattikuti Foundation and its activity.
I'm sorry to interrupt, but because I have a flight to take, so I would really take your indulgence for a minute and personally thank Dr. Henk, Dr. Ruby, Dr. Lott, Dr. Noah Bakin, and Dr. Vendrell for such a wonderful discourse you had put it together. Well, if a surgeon can understand the intricacies of how the tumor biology works, it was a perfect example of what we should be doing. Creating such a great evidence which influenced the policy in the Netherlands and encouraged other countries to fund such trials for the benefit of patients. It is amazing. Hats off to you. And Vattikuti Foundation, just to tell you, is Vattikuti Foundation is organization which is our motto is to leverage technology not for hype but for the patient outcomes. And we have been in field, and it is to be credited for bringing robotic surgery to the world at our flagship institute, Vattikuti Urology Institute. And subsequently, we have a huge network, and now we have taken the plank of educating surgeons, because these were two mottos we learned by global dissemination of robotic surgery, that any technology is a specialty within a specialty. It should not be taken as a technique. Everything you have to look in terms of translating patient outcomes. And we have a huge network which is so supportive of patient education, and we have not deterred because of this stupid unseen enemy we have in terms of COVID. So I'm really appreciative of your effort, but anything you do good comes with a price. And don't be hesitant if I invite you again for yet another course for us. And I would thank Somashekhar for putting such a great program together. Now I know why he took so much of time and pause since I called him several months ago. Dr. Somashekhar, wonderful, and it was so good, and you brought the best in the world for the benefit of people. And let me tell you, this is the largest attended webinar we have, wherein even at the close of 2 hours, we have close to 200 people listening to you, and you can go on and go on. And I just thank the supportive collaborating organization for accepting and not letting the politics and bureaucracy come in to not to let it happen. Thank you very much, and I'll beg your leave. I apologize for leaving in between, which is so engrossing, but I learned a lot, because this is something I had myself a lot of questions, but I wouldn't really take away the rights of the participant because they are rightful. Thank you very much, and look forward to talk to you again. Thank you.
Thank you very much, sir. You are always there. Education and you are synonymous, and you are allies between US, Henry Ford, Vattikuti Foundation, and India. Thank you very much for your support, not only in this, for disseminating and bringing the robotic technology to the most needy in the second tier, third tier city. Thank you very much for making time, and have a nice flight. We would now take a lot of questions. The chat box and question answer is flooded. So I know that my panelists would be very busy now to do that. Thank you. What I would do is I've compiled all the questions, so I'll keep all the speakers busy. Before that, I'm going to unmute Dr. Vijay Ahuja, who is the president of OGOI. Sir, you're unmuted. Your few words, and then I'm going to go to question and answer session. You can speak. I've unmuted you. Vijay, sir. Vijay Ahuja, sir.
Yeah, thank you, Dr. Somashekhar. Thank you for giving me an opportunity to have been a wonderful session to have all the luminaries in the field of HIPEC talking to us directly. And as we know, in India, HIPEC, you have been pioneering this technique. And we have, as I say, believers and non-believers in India. So the believers swear by it, and non-believers just say that it may not be something worthwhile. So this sort of a session really opens our eyes and widens our horizons. I really thank you for bringing this program and involving Agoy in it. And we are looking forward to the interactions, and most of our doubts, I'm sure, most of the non-believers will come to the side of the believers after this session. Thank you, Dr. Sohn.
Thank you very much. So before I go ahead with this particular thing, there are two people I think who has raised the hand. So I'm going to unmute them. Rupinder, are you there? Can you speak?
Okay, so first of all, good evening, everyone. Thank you, Dr. Somashekhar, for bringing such luminaries on a single platform so that we can share their knowledge. We have been doing a lot of HIPEC, like you said, but we too have now been able to see some different aspects of both HIPEC and PIPEC, and we hope to introduce them into our practice as well. And as you can see from the results, such evidence-based talks, and like what Dr. Vijay who just said, I think soon we are going to have a lot of non-believers turn into believers. Thank you so much. Looking forward to the question and answer session.
Thank you very much. Okay, now what I'm going to do is I have Dr. Rajiv Das who have lifted his hand. Please go ahead and ask your question. Keep it crisp, no comments, just a question, keep it crisp. And you can also introduce yourself and address to whom this question is. So Dr. Rajiv Das, please go ahead. I've unmuted you.
Yeah, Dr. Somashekhar, it's a very nice talk and a nice lecture, and so many luminaries and they presented the talk in such a lucid manner, and it's also much important data. So thank you once again. Thank you for the training you.
Thank you. You can go ahead with your question.
Yes. No. So now, actually, my question is this regarding PIPEC versus HIPEC. So, any role do you? I mean, this is just a hypothetical question. Do you think in times to come, PIPEC would replace HIPEC, considering the level of penetration, the level of toxicity, and the more effectiveness with the lesser dose? So I was just wondering, are they eminent panelists?
Thank you. I understood your question. I will allow first Professor Bakrin, then Professor Van Driel to answer. The question is, do you think since the penetration and efficacy of PIPEC by the science is much better than HIPEC, do we see that PIPEC is going to replace HIPEC in ovarian CA in any time in future?
No, I don't think so. I think that we have to fight against this idea, because PIPEC and HIPEC don't address the same population. In HIPEC, we address a population with a curative intent, and the HIPEC is just a complement to, it's just an addition to surgery, a great effort of surgery, while PIPEC is only a way to give chemotherapy. So we can't see them as concurrential. We have to see them at different time points of the lifetime of patients with ovarian cancer.
See, it's very important for audience not to get carried away. HIPEC is combined with cytoreductive surgery, so it is a curative treatment. PIPEC as of today is a palliative treatment. However, neoadjuvant PIPEC and cytoreductive surgery are being explored, not high-level evidence. Professor Van Driel, what is your thought process on this?
Well, I think I agree with Naul in that case that we don't really know how PIPEC and the CRS can be combined. So I think you have to be very aware of the complications which could come up, and we first really need evidence and proof that it's safe before we could really compare it. So I agree with Naul, Professor Bakrin.
He is a very senior gynecological oncologist who was serving Indian Defense, and now he is in a Max Cancer Center in New Delhi. Very senior executive member of Association of Gynae Onco. So Manas, please go ahead and ask your question. I unmuted you.
Yeah, it was about the last question which was asked, whether PIPEC will replace HIPEC. Actually, I think the question should be that whether the technique of PIPEC would replace HIPEC in the same circumstance. You see, you do a closure and then use PIPEC, because pressurized chemotherapy could be even more effective in a raw, deperitonized abdomen. So is there a role? Can this technology come in?
Professor
I
Bakri?
understand. Yeah, I understand. At the beginning of the experience of Marc Raymond, who invented PIPAC, they tried to replace HIPEC by PIPAC, and then they performed CRS, and then they performed PIPAC. And there was a very high rate of complication, of toxicity, but also of mortality, that made them have a step forward. And then they decided not to perform any more PIPAC after CRS. And this is so important that when we have, for instance, we can't perform any surgery before PIPAC. If, for instance, when you penetrate, you make your laparoscopy, and then you have a wound on the colon or in the intestine, so you can't perform PIPAC in the same time, because we assume that there is a huge risk of complication. So up to date, as far as we know, we can't at this time perform PIPAC replacing HIPEC.
Serosal tear, or if you need to perform a bowel anastomosis, PIPAC has got very high concentration and pressure. So the safety is, after a cytoreduction, is not proved. New evidences are arriving from Russia, where in gastric cancer they're trying to do, but as of now, we need to be very careful to do that. So what I'm going to do is, I have compiled all the questions. We will, it is sometime addressed actually already by name to whom it is. If it is not, then all the panelists are, most welcome to go ahead with that. So the first question is to Professor Henk. Why do we choose HIPEC temperature between 40 to 41 degree? Is that the only recommendation? This question is from one of my colleague, M. Ray. He is a HIPEC surgeon from All India Institute of Medical Science. He and team of Dr. S.V.S. Deo have done over 200 HIPEC in peritoneal surface malignancy. Professor Henk, to you.
And thank you for the question. Well, when the study was designed, it was quite a while ago. I think the 41 degrees was the optimal temperature for the cisplatin to work. And well, we haven't changed it until now, I think. And I know in the Dutch Cancer Institute, one of the PhD students is looking at the stability of the drugs like carboplatin and cisplatin and the temperature. So perhaps we have some new insight of this temperature, but we still remain the temperature as the initial set temperature in the OVIHIPEC 1 trial for now. Do you have any comments for that, Willemien, still?
No, I think you're absolutely right. I think the HIPEC as performed by the GI surgeons at the time the trial started, that was just common to use between 40 and 41 degrees. So that's the reason why we included that in the protocol.
Absolutely. So if we look at the phase 1, phase 2 trial, the effect of hyperthermia starts potentiating the action of chemo by 39 degree, and it peaks between 41 to 42. The moment we cross 43 degree, the bowel complications are very high. So it was found that we need to be above 39, but never above 43. So 41 to 42 is found to be the most optimal, balancing the efficacy and the complication. The next question is from our Bangladesh colleagues, Professor Janatul. She is from Bangladesh. As you know, for this webinar, we have people worldwide who have done Philippines, UK, and USA and India and Bangladesh, everywhere. This question is, why requirement of stoma in HIPEC group? So I think to both Henk and Willemien, Was there high chance of stoma in HIPEC group, or you think it was balanced in both?
Well, I think at the time we started with the HIPEC procedure, we were a bit more precautious. But you see in both groups, we had the same amount of bowel resections. They were in both groups 24%. So there was no difference in bowel resection in both groups in the OVIHIPEC trial. However, we performed more stomas in the HIPEC group. And I think that was partly because we were just more precautious at that time in the early days, because we didn't know exactly how everything would react on the HIPEC treatment. And when I look now, well, 10 years later, I personally think that we make less stomas now in the HIPEC group. At that time, we did it much more than at this time. I think we trust more to make a good anastomosis and then still perform HIPEC. I don't know. I feel that's shift personally in our clinic, and perhaps Willemien can say something about the Dutch Cancer Institute if they have also the feeling that they do less stomas now in the HIPECs.
Yeah, I think I agree, and that the pity is that we haven't asked during the OVIHIPEC 1 trial. We didn't ask for the reason why stoma was performed, so we will never get an answer whether it was precautionist or whether the anastomosis was under higher tension. And that will definitely be a subject in the OVIHIPEC 2 trial, so we will get that answer by then. If you look at all the studies, and mainly from the colorectal surgery, then there's no higher incidence of anastomotic leakage after HIPEC. So theoretically, there's no reason to be more cautious.
Absolutely. We have some answer from the Indian HIPEC registry. Over 2,000 HIPEC performed in ovarian cancer. We found that the stoma rate varied from 2.8% to 6% from institution, but it was no different now that we have learned in the last 10 years. And also now Professor Bakri knows there is a project which she and a colleague, Professor Oliver Leeuwenhoek, is undertaking with currently globally, including my center, Medical Hospital, Bangalore, assessing stoma rate and the reason in HIPEC. But in short, the answer is once you cross the learning curve of maybe 50 to 90, the stoma rates are no different. Now the next question is from Sarika Gupta. She's a gynecologist, oncologist from New Delhi, active member of AGOI. This is to Professor Willemien van Driel. You already spoke about this trial from Emory and Sloan Kettering. It was found that the secondary cytoreduction didn't improve the PFS. And what is your comment? I know you already answered it, but now that you can elaborate, do you think this is contrary to your OVIHIPEC 1, or they're two different patient subset, different drug used? Should we take it as a negative trial, or how should we infer?
Well, I think it's a different drug. Stressing the point that cisplatin is probably the more favorable drug if we need to make a choice. It's a relatively small trial, so whether the difference in complete cytoreduction rate is responsible for the fact that the HIPEC arm is not better than the control arm, well, we will never know. There's also a difference in IV cycles, and I think if you look at the concept of HIPEC, HIPEC is a combination of heat plus chemotherapy, and I think the IV chemotherapy you give, if you really want to see if HIPEC adds something, then the rest of the circumstances should be the same. So if I had to design a trial like this, then I will probably be more in favor of giving 6 cycles and then plus or minus HIPEC, because then you really know what the effect of HIPEC is additive to your standard treatment. And that's something that this trial didn't show, you cannot really answer, because the control arm received 6 cycles and the HIPEC arm received 5 cycles. So actually this trial tried to answer whether HIPEC is has the same effect as an extra IV cycle. And that's probably true. But whether HIPEC adds something to the standard therapy, that's not answered by this trial.
That's excellent analysis, actually. The next question is from Asima Mukhyavatai. She's my very close friend and colleague. She's currently based in UK. She is a great cytoreductive surgeon and an active member of IGCS and ESGO. A great friend of mine, a great scientist, not just a clinician, but also a basic science researcher in the lab. The question from her is, in India, we don't have sodium thiofluate, which is actually used in your OV-HIPEC trial, and you emphasized a lot. This was one of the reason nephrotoxicity of cisplatin didn't happen. So we usually use 70 milligram per meter square, this one, and this dose variation, is it accepted? But I can partly answer, if you see the Korean trial, which used 75 milligram, it didn't give a good result. I am also very skeptical using anything less than 100. But I let Henk and Willemien answer this question.
Yeah, I think there are more countries having the trouble or having difficulty to get sodium thiosulfate. I know in France, they have to get permission for every time they want to use it. For the States, it's also difficult. And I know for another protocol which uses extra hydration when you give them 100 milligrams cisplatin. I think this also touches on the question, what is the right dose? Should we use a fixed dose or should we use a concentration-based fluid? I think those questions are not really answered. The only thing is that if you look at all the IP trials, and if it's a HIPEC or if it's adjuvant IP chemotherapy, then all the positive trials use cisplatin 100 milligrams per square meter. It accounts for the Armstrong's trial and it accounts for the OVIHIPEC. So I think it's, well, if there is an alternative and give extra hydration, then maybe it's something to inquire with the some hospitals in the US who uses that protocol. But I would prefer to use the cisplatin 100 milligrams per square meter because we know that works. And you don't know whether, well, I think the less is probably less effective, but again, that's not really set in stone.
Thank you. Next question is to Professor Bakrin. If you encounter extensive adhesions while doing a PIPEC or a loculated ascites compartment, how would you actually proceed? Is it an absolute contraindication? Do you abandon PIPEC or would you still proceed?
It depends on the adhesiolysis you have to perform. If the adhesions are very soft and very easy to do, so I will perform PIPEC, and it depends also on the work chamber. You have to have a good work chamber, because if you have only a little or small work chamber, PIPEC won't diffuse to all the abdomen. So it's very to give instruction for all cases. But what I have to say is, if there is a wound or on colon or on stomach or on small intestine, you have to stitch it and to postpone the PIPEC.
Absolutely. If I would, let know the person who asked this question, if you go back and read the overview of the PIPEC done in all peritoneal surface malignancy by Professor Aliami, our friend Momo, which is published, more than 92% you are able to do successful peritoneoscopy. and less than 7 to 10% you abandon a procedure of PIPEC because of adhesions. So that's lost promising, and the same V2 address. So even though extensive adhesions can happen, but more than 90% of the time you can perform a successful PIPEC. Professor Bakrin, would you agree with that?
Yeah, I totally agree. And the more you are experienced in PIPEC, the less you have non-access situation.
Thank you. The next question I didn't understand. It is from Upasana. How was the past defined in the OV-HIPEC trial? Henk, did you make out what is it? I didn't understand what this. How was the past defined in OV-HIPEC trial? You know, it just came when you were giving a talk. Maybe I'll unmute Upasana later and ask what she meant. I'll go to next question. This is from my colleague, Dr. Rohit Ranade. Was the threshold to do stoma less in HIPEC? I think this is partly already answered. You know, Willemien and Henk told that initially, first 5 years, they had very low threshold. As they become experienced, they understand that probably stoma is not required. Am I right, Henk? Is there anything to add in this?
Yes, I think you're right. That explains the difference. And in the non-HIPEC group, well, we do the normal criteria for well, feeling the new bowel anastomosis is under pressure or at risk. Then we put a stoma, but that is something you decide together as surgeons at that time. And I think in the HIPEC group, we were a bit more careful and made more stomas in the beginning. And now we see that it's, I think if we measure it now, it would be probably equal.
Absolutely. Thank you. Thank you. The next question is from Kavita Sukumar. Was recurrence defined in OV-HIPEC trial as a biochemical failure, that is CA125, or an imaging appearance like RECIST criteria based? So any one of you can take. I know the answer because I read this trial in between the lines million times, but I would want the authors to answer this. Was it a biochemical failure, CA125, or was it a RECIST based on imaging?
Well, the recurrence were found by both because we at follow-up we did CA125 and we did at regular times we did a CT scan. So, and I think we found in the CA125 recurrence in about 13–14%, and the main group of recurrences was found at CT evaluations. So I think about 80% we discovered at routinely CT evaluations. So that's a practice we currently not do for our patients. In the Netherlands, we only do CA125 or radiology at the moment. The patients have complaints in their follow-up. So it's not a standard measurement at the moment. And that's followed by the ESCO trial we performed a couple of years ago. So, but now we in the OV-HIPEC trial we had set time and set measurements. So we found a recurrence also at times that the patient didn't have any complaints yet.
Thank you. That's one of the reasons when you compare the outcome of Scorpio trial to OV-HIPEC, there are two different populations. It's very important to understand. In OV-HIPEC, those patients who are amenable for upfront surgery actually underwent surgery. They're a good group. Only those who are not eligible for surgery, bad group were taken. That's why, because CA125 is used, biochemical failure are picked up very high. And that's why DFS was somewhere around 13–14 months and 36 months OS. Am I right, Professor?
Yeah, I think you're right. And I think Henk explained exactly what we did in the trial, that we had either symptoms, patients had either symptoms for which we performed CA125 or CT scan, and at specific time points, the examinations were done.
Thank you.
Yeah.
So next question is from Upasana. How was actually, this actually is a sequel of first. So the PFS was actually defined. So since CA125 was used, that's one of the reasons PFS and DFS was short in the trial, which we don't do in real time. If a patient is fine, they're walking around, we are not going to intervene.
Yeah, perhaps
so
we can also add something that we we started the PFS from the moment of randomization. And that is the moment of the interval debulking surgery. So we count from that moment, and we don't count from the date of the diagnosis or the first biopsy. So that is also a difference in our study.
Thank you very much. Henk, next two questions are from Dr. Rupesh, our colleague. He's a very good gynecologist, oncologist, senior, extremely qualified and very aggressive surgeon himself. There are two questions. What percentage of your patient who would do total parietal peritonectomy? You know where this question comes from. You know, my center is a strong proponent of total parietal peritonectomy. You have seen when you came to India. We don't make an entry into abdomen. We do a systematic total parietal peritonectomy like a parachute technique. And we have 4 publications from our institution showing more than 200 patients with a better overall survival in the group who had total parietal peritonectomy, and the pattern of recurrence was more extra abdominal, so it translated into both DFS and OS. But mine is not a randomized controlled trial, but we have 3 publications from my center. It is not a standard of care, but we, in our institution, we do total parietal peritonectomy, and as per our results. So what is, I would ask this from both your group and also Professor Bakri. I can also rephrase, in which condition do you actually go for total parietal peritonectomy, and where would you do in-field selective peritonectomy?
Now, well, we have a different approach in the Netherlands, you know, and we only remove disease which we can see with our bare eye, and that we do also into, well, perhaps to reduce morbidity. So we do the debulking surgery, and we remove all the visual true tumor, but we don't remove peritoneum where we don't see anything abnormal. And of course, we know that there can be microscopic cells in that peritoneum, but still left there. But that's also why we add the HIPEC treatment now to get those cells away. And well, we find a balance between morbidity and and survival, I think. But perhaps Willemien has something to comment on that also. But it's
well, in the OVIHIPEC trial, the majority of the patients underwent a complete cytoreduction. So it's had the numbers of patients who had minimal residual disease, so less than 2.5 millimeters, is really too small to make any comments on that. To say whether the HIPEC is more beneficial for those who don't have any visible disease, or those who have peritonitis. And I think I agree that in our center as well, we don't perform routinely a total peritonectomy. We only treat what is abnormal.
Yeah, because in this webinar, my 2 colleagues who are expert in HIPEC, Dr. Ashwin KR and Dr. Rohit, have joined. They presented a fantastic paper in PSOGI Paris meet, and they got the best paper award, which showed how the recurrence pattern can be changed by doing parietal peritonectomy. Now with Vic Verwal, we are about to initiate a randomized controlled trial. So maybe until that time, I think primary peritoneal carcinomatosis is the condition where you might do this. In all other ovarian, I think the current standard is infill. I agree with you. The time to start chemotherapy was quite longer in both groups, because we have a Japan trial which says if you delay beyond 21 days, it's going to impact every month. So this is from Rupesh. The time to start chemo was quite longer in both groups. Is it acceptable to wait up to 4 weeks and beyond? Can you enlighten us?
Yeah, well, we've got a Dutch, let's start with the OVIHIPEC study. Had a difference in time to start adjuvant chemotherapy was minimal. It was 30 days for the control arm, 33 days for the HIPEC arm. And that reflects standard practice in the Netherlands. And we evaluated the results regarding starting chemotherapy, following surgery, and survival of our Dutch cancer registry, which is a registry which goes way back, 30 years back. And there the tipping time had to reduce or had to have an effect on overall survival was 29 days. So I think that had to start the adjuvant treatment, it would preferably be around 29 days in order to have to not have a negative impact on the survival. And that's exactly what you aim to do with your surgery, cytoreductive surgery, and your HIPEC. You want to minimize the complications, which causes delay in restarting your chemotherapy.
Actually, we especially looked at delay in chemo, and Dr. Ramya and Dr. Rohit and Ashwin, they have published in Pleura and Peritoneum. We looked if there is a delay in the adjuvant first-line chemo because of whatever recovery reason. We found that up to 40 days, if you have done a HIPEC, which acts like one dose of chemo, there was no impact on overall survival followed up to 5 years. If you have done a cytoreduction alone, anything beyond 30 days had an impact. So we have a paper where delay in chemo impact in HIPEC and non-HIPEC group. It's very interesting. You can go back and read that. And when we are done HIPEC up to 40 days, it was okay. When it is 30 days for non-HIPEC group. The next question is to Professor Bakrin. This is from Dr. Revan, surgical oncologist from Hyderabad. Gas is better than liquid. You know, gas is PIPAC, liquid is HIPEC. So don't you think PIPAC at some way you can, I know you answered already, but would you sort of take this question, Professor Bakrin?
Yes, of course. I would say that PIPAC looks like gas, but it's not exactly, it doesn't react exactly like a gas, because when you look at the distribution inside the peritoneal cavity, you see that there are some heterogeneity in the distribution, and there are, for instance, more doxorubicin just next to the capnopen, and less doxorubicin when you go far from the capnopen. And I would say that it looks like a gas, but it doesn't act exactly like a gas. This is the first part of my answer. And I think the second part I would repeat, because I think it's a very important message, and it's very important to take into account this data. I think that up to date, we can't offer CRS and PIPAC to our patients because previous experience show a huge amount of toxicity, and if we want to, we have to assess it into a trial. Even if I know that some data from Russia and gastric cancer are quite promising and positive for this association.
Thank you very much. The next question is from Professor Yudi Bafna. He's a senior most gynecological oncologist from a regional cancer center from Bangalore, India. He's a professor, and hundreds of people have been trained under him. Excellent surgeon himself. I have unmuted you, Bafna. Can you go ahead and ask your question directly, please?
Yeah, my question is to Professor Van Driel. I would like to ask you, between no HIPEC and HIPEC groups, the non-HIPEC group not only had one cycle of chemotherapy less, but the duration between the third cycle and the fourth cycle also was at least 3 weeks before the surgery and 30 days after the surgery. So very long time with no chemotherapy in non-HIPEC group. So don't you think it is unfair to compare these two groups under such circumstances?
Well, I think that's, if you want to find out what the extra effect is of HIPEC, then you should compare a group receiving HIPEC with the standard therapy. And the standard therapy is as it is. It's neoadjuvant chemotherapy, surgery, and adjuvant chemotherapy. which it includes 6 weeks of no chemotherapy between the 3rd cycle and the 4th cycle. And adding HIPEC, the HIPEC is a treatment consisting of side radical surgery, rinsing the abdomen with chemotherapy and hyperthermia. So if you want to find out what the effect of HIPEC is, then this is the design you should do. If you want to compensate for that, then you will never find the answer what the effect of HIPEC is.
Absolutely. And we have now the trial which has surgery with normothermic wash and hyperthermia. Probably that will clearly answer. Yeah. Many people say hyperthermia roughly adds 4% extra benefit in animal model. If you see, we need to just check that. Thank you very much. The next question, I think you can take carboplatin, cisplatin. Is carboplatin stable at 41 degree? We know cisplatin is stable at 41. But isn't carboplatin a good intraperitoneal drug with less toxicity? Why it's failing?
Well, I think the active, once you administer the cisplatinum in the, or carboplatin in the abdomen, then the active form of cisplatinum stays longer in place than the carboplatin, which is the reason why the cisplatin is a more favorable choice.
Thank you. Thank you very much. I have a question from Asima. I'm a great admirer of Asima. I've unmuted you. Asima, can you go ahead and ask a question? You have written one caution is the success of HIPEC should not push everybody to interval cyto reduction, where even now we know if you can cyto reduce upfront, it can never be equivalent. Asima, can you go ahead and ask your question? I unmuted you.
No, it's just a comment, really. I think the success of HIPEC, because we don't have the results of the HIPEC with primary surgery yet, but people should not be thinking that it's a time to really go more and more neoadjuvant chemotherapy and just compensate with HIPEC, because it does require quite a lot of effort to put up a primary cytoreduction program. I think what I'm trying to say that sometimes in centers, and that's just based on my experience and talking to a lot of people in the field, when you have centers who are really doing 70 to 80% neoadjuvant chemotherapy and interval debulking surgery, it sets up a culture such that your primary surgeries are also more or less look like your interval debulking surgery. Whereas when you have a culture setting where majority of the patients really, I think if they're fit, they should go for primary surgery, then your neoadjuvant chemotherapy patients also have a better surgical quality. So it's just a bit of a caution that people should just not think that we have a solution to do more and more neoadjuvant chemotherapy, but that's a personal opinion, I think.
So I would request Driel to take this question, and there is one more question from Tapan Chauhan. HIPEC.
Can I comment on this?
Yes, please.
Because I think you're absolutely right. And I think if you have your NDT, you discuss patients, then it would be, very good to have a system in place where you can objectively decide that this patient has too much disease on board to get an effective primary CRS. For instance, based on the trust criteria and the whole clinical picture. So you can objectively have some reasons why you go for the primary CRS or for the neoadjuvant chemotherapy. In that way, you can prevent that patients get neoadjuvant chemotherapy in those cases where primary CRS would be very good possible.
Thank you. Until your OV-HIPEC 2 trial is complete, can we offer HIPEC with CRS in upfront primary cytoreduction? This is a question from Tapan Chauhan. What's your thought process? Yeah, our trial would take 5 years to recruit, 5 years to wait, 10 years, and then I think our surgical career is out, our next generation. So what do you think? Is it trying to offer upfront CRS? Because, if it works, it would definitely work the best in upfront. I don't know. What is your thought?
Well, I think that's an ethical question, and depends very much on how quick you want to implement new strategies which haven't proven to be active yet. The same goes for surgery for recurrent disease. We've got a desktop trial. We're all very anxious waiting for the final results. So we know the preliminary results. We also have the trust study, which will give an answer on the question whether primary CRS or interval CRS, which of the one is better. So I think it's a difficult question. We all want. I think in medicine, I think we tend to think that if you do more, then it's better, and I'm not sure if that's always the case.
I think the best thing is to write a protocol, get a IRB approval, and then do it as a part of it, which we have been doing in my center. So which we have been doing. Out of the entire HIPEC for ovary, more than 200 in our center are upfront. And it is not a randomized trial, but when we compared, we had a best result in upfront. Maybe a bias of case selection, so only a randomized controlled trial can answer. There is one question from Bangladesh, Professor Shahana. What is the rate of reoperation in your HIPEC group? This is a misnomer people have. HIPEC is very toxic, quality of life comes down, a lot of patients end up with multiple re-exploration obstruction. I would recommend everybody to go and read the quality of life paper also published from OV-HIPEC. First, it was presented in ESMO. I was there. I heard that firsthand, and then it is also published. But I would tell Henk, what is your answer? You have presided over and now taking over the upfront surgery, OV-HIPEC 2. Is reoperation rate in HIPEC group more?
Well, I don't think we have a bigger rate in the HIPEC group. I don't know exactly the date for reoperation, but in our hospital, I can think there was no difference between HIPEC or non-HIPEC. Perhaps Willemien knows the data exactly, but
well, I think to be honest, we didn't report the Clavidindo classification. So I think we really have to go back to the data to look this question, to look for the answer to this question. We used the CTC adverse event scale, and there was no higher percentage in anastomotic leakage or bleeding or post-operative bleeding. So from that, I think there was no difference in reoperation rate. And in addition, there was no difference in reinitiation of the chemotherapy. So I don't think there is a huge difference in this respect.
I would request Professor Bakrin to step in, because a very large volume from her and Oliver Glehen group has actually been published, the morbidity and mortality. From what I analyzed from our Indian HIPEC registry, the morbidity mortality is high only during the learning curve. HIPEC is something which has got a long learning curve, unlike any other surgery. So once you pass the learning curve, it was same for us. But in learning curve phase, definitely morbidity was little high. But Professor Bakrin, most of your publication I have read. Can you please throw a light from French group?
Yeah, I totally agree with you. I don't think that there is more reoperation in HIPEC group compared to CRS. But I think I can't answer honestly concerning the learning curve, because as in our center, we treat patients from other origin, from peritoneal carcinomatosis, rare diseases, pseudomyxoma, etc. Our learning curve is far away. So we will be able to answer, because we have there is an implementation of HIPEC in a new team, and we are studying their learning curve, and then we will be able to answer with the data. But as far as I know, there is no difference in our practice. So it's not trial, but in our practice, there is no difference in the reoperation between HIPEC and non-HIPEC patients.
Absolutely. And for all the delegates, I would welcome you to read Professor Kusamura Shigeki's papers. The largest work on learning curve and HIPEC is from NCI Milan. My very close friend, Professor Shigeki Kusamura, along with Marcelo Daraco. A lot of insights for people to start the learning curve is there. My colleague, Dr. Ashwin and Rohit, tried to put a learning curve for my group, and they just couldn't put, because last 20 years over 1,600 cytoreduction group of our surgeons had done. We don't know where the learning curve of cytoreduction ended and where the learning curve of HIPEC began. And even today, Dr. Rohit is never able to put learning curve. Everything has to come to end. There are 100 questions. I would probably end this with this question. You say 2.5 millimeters, CC0, CC1. How is it like? A scale, a magnifying glass, or, oh, okay, two surgeons agree, nothing seen to my eye. I know that, Dr. Amita has asked this question. A lot of people have asked, how is this 2.5? Just you agree? Or you're going to measure it?
It's a historical way to measure the residual disease. But I think that what we all know as surgeon is that this CC1 apply particularly, for instance, when you have a huge amount of tiny nodules on the mesentery, and then you try during hours to clear it up. But honestly, you can't say that you don't have forgot one nodule, and that's the reason why you say CC1. But in reality, I don't think there is a situation where you left really 2.5 millimeter of disease. What is your opinion, Professor Somashekhar?
I will request Henk and Willemien to answer, then I'll take it. Because we practice total peritonectomy exactly for that reason. And I would request both of you, Henk and Willemien, to answer this.
In general, in the Netherlands, well, we say optimal debulking will be less than 10 millimeters. But we make a differentiation between those. We go up down to 5 millimeters, and we go down to 2.5 millimeters. And what we actually saw, I think, in the OVIHIPEC 1 trial was that the HIPEC performance was better in the patients with 2.5 millimeter residual diseases than the, for instance, 7.5 millimeter disease. So that is actually perhaps a different identity, as Professor Bakrin just mentioned. Those very tiny little nodules for 1 or 2 millimeters, which you can't remove probably everyone, but you can manage them perhaps with the HIPEC. And that's also why we included this difference now in the OVIHIPEC 2 trial. Willemien, do you have something to add?
Yeah, I think if you look at the OVIHIPEC 1 data, then the numbers are too small to draw any conclusions if there's a difference in less than 2.5 millimeters or less than 1 centimeter. And what we implemented in the Dutch registry is the PCI score, which forces everybody performing cytoreductive surgery to note down, to record the amount of disease left following the surgery in every region. So I think if you've done a lot of these CRS procedures, then you know when it's 2.5 millimeters and when it's 1 centimeter and when it's 2 centimeters. It's and what we notice in the implementation phase is that that's also a very good way to standardize the way you evaluate the abdomen after the surgery. So I think in the Netherlands, by the end of this year, everybody will do this the same.
Absolutely. It's very important to understand a unit which runs HIPEC program. Practically everything in the abdomen is cytoreducible. The only limiting factor is nodules on the small bowel. So you can't end up with short gut. So what we normally evaluate is If small bowel is the only place where miliary nodules are going to be left behind, I would go all out in pontohepatitis, lesser, omental bursectomy, everything. And then I would accept it as 1 to 2 millimeter on the bowel, and still I know HIPEC would help. So don't try to use this 2.5 millimeter on a parietal peritoneum or a glisten capsule or a diaphragm or in a pouch of Douglas. They're all cytoreducible. If you've done full maximum cytoreduction and the only miliary nodules are small bowel, and you can't end up, we know that more than 3 bowel resection is a morbidity factor in HIPEC. I would then accept that as 2.5 millimeter. That's the only place I would accept. Every else where effort can be translated. Professor Bakrin, do you agree with this philosophy?
I totally agree.
Thank you. Thank you very much.
It has to be reserved to places you can't cytoreduce.
Yeah, I agree.
Thank you. I have to end it. It's never going to end. And then my Dutch colleagues will next time never accept my invitation if I keep going on. And then Professor Bakrin would be thinking, this is much more than a cytoreductive surgery happening. I profoundly thank on behalf of Vattikuti Foundation, Indian Society of Peritoneal Surface Malignancy, Association of Gynecologists Oncologists of India, to my Dutch colleagues, Driel and our colleague, Professor Henk, my great friend who loves Indian spicy food for a change, and Professor Bakrin. Out of all the odds, you bet the odds, and then you did a fantastic talk. And all the delegates, and we had 500 registration. Thank you very much for this. And what a wonderful event and effort it had been. It's pleasure. I hope we can host all of you in India live, not just academics. We mix fantastic Indian hospitality. Thank you very much. And I will just give few last parting lines to Willemien and then Henk and Bakrin, and then I'll end this program. Please go ahead, 3 of you, one after the other.
Well, thank you very much. It was a great pleasure. I had a wonderful afternoon, and I think a lot of interesting discussions went on. So thank you very much for hosting this.
Thank you.
Yes, thank you, Somu, for hosting this, and also the Vattikuti Institute. Great to make this possible. And I think it's quite unique that we have so many participants with actually the same interest on this really interesting but small topic in the world, because all the people who are actually here were really interested in HIPEC, which is great to see. Thank you all.
Bakrin, I'm greatly fascinated with the work Bakrin has done. I would request everybody to visit ResearchGate and see her work right from basic science to the clinical translation. And
thank you very much. Thank you for invitation, and thank you. It was a great opportunity for me to share with you my experience and to learn a lot from you. And I'm looking forward for the next event.
Thank you. And then I'm happy that today I received a letter from Professor Paul Sugarbaker that for the first time they've expanded the executive committee of PSOGI, and they've inducted me as a executive member, which is a very rare honor, and I'm very happy to share with my colleagues. And first time it is expanded, and then the EC committee invited me to be one of executive member. Thank you.
Congratulations.
Congratulations. Happy for you.
Thank you. And Dave, over to you for parting, and thanks very much, Dave. Without you, it wouldn't have been possible. Fantastic evening we had, and India, it is now, time for dinner. And thank you very much, Dave. Over to you to end the comment.
Well, thank you everyone for an incredible program, an incredible master class. It's hard to imagine everybody getting together for so long and sharing so much information, and your audience stuck with you, which means that meant a lot to our attendees today too. So thank you. I also want to thank Dr. Van Stein and Dr. Ronson for their part in this. Thank you and goodbye.
Thank you very much.
Thank you, Dave, for making this possible.
Yeah, thanks.
Thank you very much.
Bye.
Well, have a good weekend, all.
Yeah. Nice.
It's time for a cold beer, I think, now.
It was very easy, 500 people registering, and this is never going to end. And that if you come to India, it would go on for 5 hours and you will never sit. And even when you go for a dinner, 100 people would come, keep asking questions. And you know, India is known for good hospitality, and then they will take all the knowledge and they want to interact. Henk, thank you. My personal thank you for all the effort you did. You know, great. Thank you very much. Thank you.
Well, thank you for organizing.
Next time we come together to India.
Yeah, to India. Yeah, that's a good plan. Yeah.
We have so much to say now.
Thank you. Thank you very much.
All right.
Have a nice day.
Okay. Bye-bye.
Bye.
Thank you.